Okay, sir.
Today Ganesh ji has joined?
No, sir, not yet.
Not yet, no? Okay. So Singh, please start recording.
Yes, sir. Switched on.
Done? Okay, 1 second. Yeah. So good evening, everyone. Myself, Dr. Prashant Gowda, Secretary NNF for Chapter Karnataka. First of all, I would like to request all the neonatologists who have been part of NNF, who is an NNF member. We request, and election is on from December 5th till December 20th. So we request all of you to kindly vote and not to miss. And please vote and choose your candidate. Thank you. So with this message, we want to start our session for today. As we are continuing the journey of knowing all the ups and downs in the establishment of hospital and health infrastructure, this webinar series has been running from last 4 months almost, with so many speakers and so many stalwarts of industry have come and have spoken, both medical and non-medical. So today we are continuing the same thing, and we have a topic on today, that is significance of hearing screening, OAE, BERA and diagnostic audiometry, purchase, setup, and we have another topic about medical instrument calibration and refurbished equipment. Is it safe and feasible or not? So we have two well-renowned speakers, Dr. Ranjith and Mr. Vanam Naidu Babu. So on behalf of NF Karnataka, we would like to give a warm welcome to you, sir.
Thank you, sir.
So today's session will be moderated by me and Dr. Dinakar. And today's session panelists are Dr. Ajit Kumar. He's my MBBS batchmate and a good friend of mine, and he is a well-renowned ENT surgeon practicing in Dakshina Kannada. And Dr. Meghna Kashyap. So I know her very well, and she's been running Child Development Center from last half a decade, more than half a decade, 6-7 years, and she has got a good experience and knowledge about newborn screening and the what is the utility of that and how it can impact in the management of child development care. And we have Dr. Mrudula. She's a speech therapist and audiologist. So her profession is that. So we're going to take their perspective and views regarding today's topic. So first of all, I would like to introduce Mr. Ranjith Rajeshwaran. He's a professor and the director of MURF, Institute of Speech and Hearing Private Limited, Chennai. And this is a quite famous private limited company, which most of us know, and most of the audiologists and ENT doctors know it very well, and they've been doing a very tremendous job. And he's an audiologist from Madras ENT Research Foundation Private Limited, Chennai, and he has done masters in audiology and speech language pathology. PhD thesis he has completed. Is an expert committee member of Rehabilitation Council of India, that is RCI, and he has been president for Indian Speech and Hearing Association Tamil Nadu. His field of interest is auditory neuroscience, and he has vast experience of almost 2 decades experience, more than two decade experience in hearing implants, and he has been awarded with Best Teacher Award by the Tamil Nadu Dr. MGR Medical University. And he has established Hearing Restoration Center in SAARC countries and Africa. He has worked in a lot of research subjects as well, and he has done research publication, more than 25 papers in international and national journals. He has been an invited speaker for major international conferences and seminars. Is first in India to introduce auditory steady state response, first in India to perform electrically evoked auditory brainstem implant for cochlear implants, first audiologist in India and Southeast Asia to perform auditory brainstem implant to restore hearing in children with absent inner ear and auditory nerve. He has introduced the first formal training for auditory habilitationist in India, has been involved in various community services as well. So we are very privileged, Mr. Ranjit, to have you as our speaker. And we have our second speaker. First, I think he's been in global biomedical services, SN Medical Systems, and he has got multiple branches across Bangalore, Chennai, Mumbai, Kolkata, and Bhubaneswar. That is Mr. Uh, uh, I hope I'll spell his name properly. Vanam Naidu Babu. He's the CEO of this Global Biomedical Services India, and he's going to talk on a very vital topic of refurbished equipments and maintenance of the equipments as well. So, without wasting much of delay, now I invite Dr. Ranjith to start the session. Over to you, Dr. Ranjith.
Thank you very much, Dr. Prashant. And first of all, I would like to thank the NNF and the core team working with NNF for setting up such a wonderful online meeting. And and thank you so much for this elaborate introduction. And without wasting much of time, I'll go dive straight into the presentation. Today's presentation was on significance of OAE, ABR, and diagnostic audiometry purchase and setting up. Now, the way I wanted to handle this particular topic is a little different. So first, I would like to give you an overview of why you need a diagnostic audiometry. So the moment we understand the need for diagnostic audiometry, then we will understand the need for purchasing and the way we have to set it up. So, I'm going to slightly take a parallel road to give a better perspective of this topic. So first, I'm going to talk about the assessment of the auditory system. So I'm just going to give you an overview of it for all the participants to understand. I understood that it's a mixed participants. Vast majority of them are neonatologists. There are also some biomedical engineers who's also present in this seminar. So I'm going to take a little, give you an overview about it. Now, before we go into this topic of audiometry, I would like to make a very important statement. So we know that ear is one of the most sophisticated sense. Yet it is the only sense that can be restored, even lost completely. It's a very, very strong statement. That is, out of all the five senses, hearing is the only sense that can be restored, even lost completely. So which means even if there is no ear, if there is no inner ear, if there is no auditory nerve, you can still restore hearing. This is a very, very important thing. But if you ask me, is it possible in this country? It's very much possible in this country. And we have been doing it for almost 2.5 decades of this work. And we are not second to any developed countries in this procedure. So, and when I mean I don't mean it MERF alone. I mean it a lot of other competing ENT surgeons as well in this country. So they're all doing a very good work. And hearing restoration is not a new thing for the otologists and audiologists in this country. So the point is, we can restore hearing even lost completely. But before we understand how do we restore it, we need to understand how do we detect the problem. So restoration is a treatment, but the most important thing is diagnosis. Now, as I told you, ear is one of the most sophisticated systems. So hearing is one of the most complicated function here. Now, if I'll give you a brief overview of it, and I know most of you know the anatomy and physiology of hearing, but I would like to give you just an overview just to get the cream going on. The ear has got majorly three components: the outer ear, the middle ear, and the inner ear. The outer ear has a different function, middle ear has a different function, inner ear has a different function. And beyond the inner ear, you have the auditory nerve, where the signals are taken to the brain. Now, they have a different function. Now, in the auditory nerve, the way the nerve carries information from the cochlea to the brainstem is totally different from the way the signal is being transmitted from the brainstem to the auditory cortex. The way the signal is transmitted from the auditory cortex and within the cortex is totally different. Though every system of the auditory pathway functions differently, as I told you. Now, all the entire system put together has a totally different function. So that is why the physiology of the auditory system is so complicated. In spite of doing so much of research in this all over the world. And my understanding is we haven't even penetrated more than 1.5% of these signs of auditory system. However, so now what is the function of hearing? So I've been talking about the anatomy and the physiology of the ear, but what is the function of hearing? The hearing is basically required to detect a sound, to discriminate two sounds, to identify a sound, and to comprehend a sound. Now, without this function, hearing is useless. So there is no point in having a ear when these functions are not carried out. When you have a normal hearing, but you can't detect a sound, then what's the point in having hearing? You have a normal hearing, but you cannot discriminate between two sounds. What's the point in having normal hearing? So you can have a normal hearing, but you can't identify the source of the sound. Then what's the point in having normal hearing? Now, you can have a normal hearing and all detection, discrimination, identification, but you can't comprehend what you hear. You can't understand what you hear. What's the point in having normal hearing? So when I mean hearing, hearing has got multiple responsibilities. It is for detecting a sound, discriminating a sound, identifying a sound, comprehending a sound. So all these functions has to happen very systematically and synchronously. Now, when we fail in any of these, when these functions, that means there is some hearing loss or there is some auditory dysfunction. So now how do you identify the auditory dysfunction? So the way to identify auditory dysfunction is to assess the entire auditory system. So when you assess the entire auditory system, right from the external ear to the auditory cortex, then you will be able to pick up the exact pathology or the dysfunction in the auditory system. Now, we all know that there are two types of tests to diagnose. This is quite common in all the faculties of science. Now, one is a subjective test, another one is an objective test. Subjective test, you have to depend on the subject, and objective test, you don't have to depend on the subjective response. But in my opinion, there's nothing called an objective test. Every test is a subjective test. But the question is, who is going to be the subject there? So if the patient is the subject, then it's a different thing. When the even if it is an objective test, so this is a very important statement that I want to make. Even if it is an objective test, it is not a objective test. It is a subjectively reported objective measurement. The ABR measurement can be made automatically, or any measurements can be made automatically, but the interpretation has to be done by a subject, a professional, or a skilled person, or a clinician who is an expert in that particular area. So at the end of the day, when it comes to diagnosis, everything is subjective, nothing is objective. Maybe acquiring a data is an objective, but interpreting the data is subjective. So it is all subjectively reported or subjectively interpreted objective testing. Okay. However, when we mean objective testing here, let's only talk about the way we acquire data from the subject. The subject here is the patient, right? So when you classify the subjective testing and objective testing, there are a lot of tests which can be done subjectively, and a lot of tests can be done objectively to assess the auditory system. See, one of the commonest subjective tests is called the pure tone audiometry and the speech audiometry. And commonest objective test which is done in everyday clinical routine is emittance audiometry, which is a test to assess the middle ear function, and auditory evoked potentials. That's a test to measure the evoked potentials right from the cochlea up to the auditory cortex. So these are the two commonly used clinical procedures in the audiological practice. Now, how do you test hearing? So hearing, as I told you, is see, you can only hear when the signal reaches the auditory cortex. You will never be able to hear or identify a sound or discriminate a sound unless the signal reaches the upper brainstem or the auditory cortex. So these are two important things. Now, the way to establish the sensitivity of hearing, when I mean sensitivity of hearing, which means if you want to know whether this particular child or subject has normal hearing or an impaired hearing, you need to do a hearing test. The test quite commonly used to assess the sensitivity of hearing is called the pure tone audiometry. Now, this is the gold standard test. So this is a very common test, and this test can be done using two modalities. One, an air conduction modality. Another one is a bone conduction modality. Now, what is air conduction modality? What is bone conduction modality? An air conduction modality is nothing but giving a stimuli through the external ear canal through air conduction. A bone conduction stimuli is nothing but giving a stimuli through the bone conduction. See, the cochlea, if you look at the cochlea is a bony structure. This bony structure is housed inside a petrous part of the temporal bone. So it is again housed inside a bone. Now, to reach means sound is nothing but a vibration. When the vibration is transmitted in the air, it is acoustic. When the vibration is transmitted into a solid medium, it is mechanical. Now, if you transmit the vibration through the bone, which is a solid medium, the vibrations can reach the cochlea, which is the inner ear, and the patient can still hear, or the subject can still hear. Or you can give the stimuli as an acoustic medium, which is called air conduction, through the external ear canal, and it will go, the sound will reach the cochlea through the middle ear. That means it will be transduced by the eardrum and the ossicles, and then it will reach the middle ear, sorry, the inner ear. So there are two modes of testing. Now, the reason why we have to do the two modes of testing is, if you look at this image, this is the external ear canal, and this is the middle ear. Now, when you give an acoustic stimuli, the signal goes through the ear canal, has to pass through the middle ear and reach cochlea. Now, if there is a problem in the middle ear, what happens is the amount of signal that reaches the cochlea is attenuated. It is reduced because of the pathology or some kind of dysfunction which is happening in the middle ear. But when you give a stimuli through the bone conduction, the middle ear pathology does not affect the signal transmission to the cochlea. So by testing both through air conduction and bone conduction, you will be able to identify whether the hearing loss is in the inner ear or in the middle ear or in the external ear. So this is called differentially you can diagnose the type of hearing loss here. Now, I think most of you might have seen a diagnostic audiometer. So this is a diagnostic audiometer. You need to use a headphones, and the room has to be a sound treated room, and the less than 30 dB ambient noise. And ideally we use a 2-room setup to do this testing. And this is the degree of hearing loss. So based on the, this is the audiogram. If you look at this screen over here, and the audiogram is nothing but you have the intensity scale versus the frequency scale. So you're going to test each frequency at a different level and then see what is the minimum level that the subject can perceive the sound. That means a level below which he can't hear, at and above which he can hear all the signals. So this is called the threshold of hearing. So we establish the threshold for each frequency, and based on the threshold, we calculate the degree of hearing loss. Right. Now, as I told you before, we use both air conduction and bone conduction testing. If both air conduction and bone conduction thresholds are normal, okay, or within normal limits, it's normal hearing. When the air conduction threshold is affected and the bone conduction threshold is normal, you see this is the bone conduction threshold and this is the air conduction threshold, which means there is a problem in the middle ear, as I told you earlier. Now, if the air conduction and bone conduction are affected, and the gap between the air conduction and bone conduction, that means the threshold difference between the air conduction and bone conduction is less than 10 dB, then it is a problem in the inner ear. If the difference between the air conduction threshold and the bone conduction threshold is more than 15 dB, there could be a problem in both in the middle ear and also in the inner ear. So based on these configurations and patterns, we'll be able to differentially diagnose the type of hearing loss in this case. Yeah. Another thing is the configuration. So if you look at the audiogram, it has got different configurations. So based on the configuration, you can also suspect certain pathologies of the ear. Now, the next most important thing is an aided audiogram. So aided audiogram is nothing but, see, you might have seen a lot of children wearing a hearing aid, or you might have seen the ENT surgeons or a pediatricians or an audiologist or a speech therapist recommending a hearing aid for a particular child or an adult. But what is fun in giving a hearing aid when you know, if you don't test whether the hearing aid is sufficient enough? So how do you test whether this hearing aid is doing its job? When I mean it is doing its job, how do you know whether this particular patient gets adequate benefit with hearing aid? So how do you do it? You put a hearing aid onto the patient, and again you do an audiometry. So, and then you see what is the level of hearing that that he is hearing with the hearing aid on. This is called the aided audiogram, which is done when the hearing aid is in situ. And this is usually done in a sound field. A sound field is a different setup where instead of wearing a headphones, the sound is delivered through a free speaker, which is kept 5 feet away from the patient at a 45-degree angle. Now, once you measure the thresholds, and thresholds are plotted here. Now, look at this particular audiogram. So this audiogram is very, very important, and this is called the speech banana. Speech banana means at the end of the day, why do you need to hear? As I told you, the one of the primary function of hearing, if I ask anyone, what is the primary function of hearing, everybody will say the primary function of hearing is for communication. But I differ with all of them because the hearing is not for communication. You don't need hearing for communication. You can even communicate without hearing, because that's what most of us do. We keep texting each other and we can still communicate. So you don't need hearing for communication at all. But at the end of the day, the reason why you need hearing is a sense of security. And because of that particular sense of security, and later we used this hearing for communication. And because over a period of years, because of the extensive use of hearing for speech and communication, the neural network for the between the auditory and the speech area has become very, very strong. And that's one of the important reason why the arcuate fasciculus in the brain is very strong. So without going much into that particular part of science, but what I want to tell you here is this speech banana is nothing but these are the sounds, fundamental speech sounds, okay, with different frequencies at different level of intensities, which means when somebody is speaking to you at a normal intensity, when they say sound sa, and this is where the sound sa falls. This is the frequency of sound sa, somewhere between 4,000 to 6,000 hertz, and it is almost around 40 decibels. Now that is the normal conversational level. And when somebody speaks a word called sun, okay, sa is here. The sa is here. Is here. So this is the frequency of na is somewhere close to 750 hertz. And A is somewhere very close to 750 hertz, but A is louder than Na. So this is the average acoustic weightage that is given across frequencies for speech sounds. Now, if the benefit from the hearing aid is above the speech banana, that means this particular child or a patient will hear sounds, but he will not be able to understand speech. Now, if the aided thresholds are partially within the speech spectrum and partially outside the speech banana, which means this particular patient will be able to hear all the speech sounds in this particular area, which is ma, na, a, ga, all those sounds you will hear. But the sounds beyond this level, that's beyond 2 kilohertz, which is outside speech spectrum, which is this fricatives and sa, fa, all those sounds, he will not be able to hear, which means he will have a kind of uh, um, misunderstanding. For example, when you say sun, in this case, he will only hear an. He will not be able to hear sa. So you will only hear an. So again, the point here is this hearing aid is not giving full benefit to him. So the best hearing aid is a hearing aid that gives the aided threshold should be well within the speech banana. Now, this is basically when it comes to the threshold of hearing, that is a detection of the sound. And after you fit the hearing aid and after you do this aided audiogram, again you will have to do some speech test, which is called the speech audiometry, which I'll be highlighting in my next few slides. So this is the function of the pure tone audiometry. So pure tone audiometry is a gold standard test. Now the pure tone audiometry, as I told you, it only tests the sensitivity of hearing. And you can, the clinical application is to identify whether the degree of hearing loss and the type of hearing loss. Now, when it comes to middle ear, so middle ear, there are three important things that we can evaluate. One is the eardrum, the ear ossicles, and the cavity of the middle ear. Now, the middle ear cavity is filled with air, and the eardrum is is tilted slightly at 55-degree angle, and there are three ossicles which conducts the mechanical signals from the eardrum up to the inner ear. Now, all these things are very, very important for sound conduction. Now, there are two types of tests that you can do using you can use to assess the middle ear. So one is called the tympanometry, another one is called the reflexometry, acoustic reflex testing. Now, tympanometry is basically to test the cavity, the structure of the cavity, the position of the cavity, and the position of the tympanic membrane. So based on that, we will be able to infer many informations. Like whether the eardrum is normal or the eardrum is perforated, if there is a fluid instead of air in the middle ear cavity, instead of a normal middle ear pressure, is there a negative pressure or a positive pressure, or is there any bone growth in the middle ear cavity? There is, especially in the otosclerosis cases where there is a ossification at the foot plate of the stapes. So all these things can be interpreted using this tympanometry, and this is a subjective test. Though it is a subjective test, it has to be objectively interpreted. Now, based on the type of the graph that we obtain, we can differentiate or we can predict the pathology in the middle ear. Now, acoustic reflex is another interesting thing. Now, middle ear has got one more important function actually. That function is basically to reflex reaction to very loud sounds. Now, what is the reflex in this particular case? A reflex is nothing but when you produce a loud sound, the sound travels from the cochlea to the auditory cortex. Along the auditory pathway, some auditory fibers from the superior auditory complex or a cochlear nucleus, they also connect to the facial motor neuron. The facial motor neuron is a neuron that supplies that's very important for facial nerve. Now, when this triggers the facial motor neuron will trigger the facial muscle, and stapedial muscle, which is part of the middle ear muscle, is also supplied by the facial nerve. So when the stapedial muscle is being stimulated, the stapedial muscle will contract and it will tighten, or it will put more resistance to the middle ear, right? So this is a very important reflex function. Now, based on this, what we do is we use this reflex function to assess the auditory system as well. So this is the reflex. So when you give a loud sound, and if you can measure a reflex, what it means the auditory reflex network is intact. The inner ear is functioning, the signal is traveling in the auditory nerve, and the signal is traveling back in the seventh nerve, and the stapedial muscle is contracting. So this system is working very well. So which means we can confirm that middle ear is normal. We can confirm that the cochlea is functioning. You can confirm that auditory signals are traveling in the auditory nerve, at least up till the lower brainstem. And that the facial nerve is also functioning. The stapedial muscle is also functioning. So all this information can be inferred by measuring the acoustic reflex. Now, another important thing which we can also do an indirect measurement is based on the level of the acoustic reflex. You can also predict the hearing sensitivity. Okay, and now the acoustic reflex is also used to predict the retrocochlear pathology. For example, if there is a fatigue due to tumor, when there is a compression in the auditory nerve, let's say that when there is an acoustic neuroma, when there is a compression in the auditory nerve, and because of the compression, the auditory nerve function goes down. Now, what happens as a consequence of that? The reflex will start decaying slowly. This is a normal reflex, which means when you give a stimuli for a period of 10 seconds, you see a reflex constantly happening for 10 seconds completely. So this is the reflex, what I mean. But in a patient with a pathology beyond the cochlea, you see that there is a decay. There is a reflex, and then slowly the reflex goes down. There is a decay happening more than 50% of the time. So this indicates that there is some kind of an auditory nerve pathology. This could be due to any kind of pathology. Quite common pathology is the compression in the auditory nerve, which is due to the acoustic neuroma. Now, the clinical applications of the acoustic stability reflex that have been, which I've already told you, any middle ear disease, if there is an otosclerosis, to look at the cochlear hearing loss and also looking at the loudness recruitment. And you can also determine the site of seventh nerve lesion as well using the acoustic reflex, because in case if there is a small lesion in the seventh nerve, the question is whether the lesion is above the facial motor neuron or below the facial motor neuron. You'll be able to identify it based on this reflex. Now, the next most important thing, we have covered the middle ear. Now, how do we assess the inner ear? Now, before we assess the inner ear, let's understand what is happening in the inner ear. The inner ear has got two functions. One is transduction and transmission. Transduction means it converts the mechanical information into electrical information. So this is primarily done by the hair cells. Now, there are two types of hair cells. There is something called the inner hair cell and the outer hair cells. Now, the outer hair cell and inner hair cell has two different functions. So they don't have the same function. They have two different functions actually. Now, the inner hair cell is primarily in converting the incoming sound and transmitting the transducing the incoming sound. The outer hair cell has got a little different function. The outer hair cell gets information from the cortex. And what it does is, this outer hair cell will modulate the information, will modulate the level of functioning happening in the external ear. So it can attenuate the signal, which means the outer hair cells are active amplifiers. Okay, it can either amplify the signal, it can also suppress the signal. It has got both functions to do. Now, this is very, very important, because this outer hair cell is getting information from the brain, which means whatever the brain wants to listen to is what you want to listen to, right? So whatever you want to listen to, ultimately the slave of the mind is the outer hair cell. So it will attenuate the information based on what signal you want to listen to. This is the primary entry filter for what you want to listen to. Now, but these cells are very, very, very sensitive, very vulnerable, right? Now, if you look at the inner ear, 80% of the inner ear is flooded by, I'm sorry, 80% of the basal membrane in the inner ear is flooded by the outer hair cells, 20% is by the inner hair cells. Now, that's the outer hair cells. Now, how do we assess the outer hair cell function? So, outer hair cell function can be assessed using a test called the autoacoustic emission. So, autoacoustic emission is nothing but an emission that happens in the inner ear. Now, what kind of emission the inner ear produces is, it's a mechanical emission. That is, when there is a signal that goes into the inner ear, and the signal reaches the auditory, it reaches the auditory cortex, or much before reaching the auditory cortex. There is a circuit. So that circuit, what actually does is, it actually triggers the outer hair cells as well. Now, which means when the inner ear is functioning normal, the outer hair cells will be very active. When the inner ear is not functioning normally, the outer hair cells are inactive. So that's the way that you need to understand. That means when you measure the activity of the outer hair cell, you will be able to predict the functioning of the inner ear. That's the way to understand. So, which means when you do a test called autoacoustic analyzer, the equipment that is used to test the outer hair cell is called the autoacoustic analyzer. So which means what this autoacoustic analyzer does is, the autoacoustic analyzer will measure the emission of the outer hair cells. Okay, and that is called the autoacoustic emission. Right. Now, this autoacoustic emission, there are two types of, there are two ways that you can measure this emission. One is by stimulating the ear with a transient stimuli. Another one is by giving two different tones with a different intensity and the frequency. combinations. So, and by stimulating these two types, you can actually record the emissions of the outer hair cells. Now, this is very, very important because this is a tool which is primarily used for screening hearing in newborns. Now, what does it mean? It means that um, when you measure the outer hair cell function, it means that outer hair cell is functioning normally. So it only measures the functioning of the outer hair cell in the entire auditory system. So keep that in mind. It does not measure the entire auditory system. So which means when you do a newborn hearing screening, never ever interpret that when the hearing is passed, never interpret the entire auditory system is functioning normal. It should be interpreted that only the outer hair cell is functioning normal. That's all. Now I will highlight in my next slides why I have to give more stress on this particular statement, because there are a lot of other disorders where the auditory the autoacoustic emissions are present, the newborn hearing screening is present, and you can discharge a child stating that the child has got normal hearing. But if the child has an auditory neuropathy disorder or auditory desynchrony in the auditory nerve, the OAs will be still present, right? But it does not mean the child has got normal hearing. So it's a fallacy. So never ever make a statement just because a child has passed an OAE test. It means that the entire auditory system is functioning normal. It only says that the outer hair cells are functioning normal, which means the hearing should be normal. That's it. It does not mean the entire auditory system is functioning normal, right? Now, the other functions of clinical applications of OAEs are early identification of autotoxic disorders. For example, the outer hair cells are very, very vulnerable. Now, they're very, very vulnerable for autotoxic drugs. So when there is a noise-induced hearing loss, or when there is a autotoxicity, the first when there is a excessive exposure to noise, or when there is an autotoxic drug intake, the outer hair cells are very, very vulnerable and they get affected quite fast. But it is very difficult to identify it at a very early stage just by doing a pure tone audiometry, because the pure tone audiometry will not be able to measure such a transient changes in the hearing sensitivity, whereas the autoacoustic emissions can measure those changes. So that is very, very important tool to early identification of noise-induced hearing loss and autotoxicity. Now, all that what we have seen now is only the functioning of the outer hair cells. So what about the function of the inner hair cells? Now, to measure the function of the inner hair cells, you can do a test called the electrocochleography. Now, electrocochleography measures the measures the functioning of the inner hair cell, and this can be measured by placing an electrode in the ear canal or on the eardrum, or you can even measure by placing the electrode in the lobule or the external the pinna. All that what you get from this particular testing is to look at the functioning of the inner hair cells, which means if there is a significant hearing loss, really a sensory component, you'll be able to measure it. You can also measure if there is a neural component which is affected. And if the inner ear is loaded with a lot of um, inner ear fluids, which can cause Meniere's disease, and you can also diagnose Meniere's disease using this particular test. Now we have seen how we have measured the functioning of the hair cells. So what happens beyond the hair cells? We know the signal from the hair cells is carried to the auditory cortex via auditory nerve. Now, how do we assess the auditory nerve? The auditory nerve can be assessed. The signal transmission in the auditory nerve can be assessed using an auditory brainstem response, which is called the ABR. Okay, and understand ABR is basically a test which is used to measure the neural synchrony. Okay, I mean, I'll highlight what it exactly means. Now, as you all know, ABR has got 5 different peaks, and based on the latency and the absolute and the inter-peak latency, the diagnosis is made. So let's not go in depth on it. Now, ABR can be used for 2 different purposes. The ABR can be used for estimating the threshold. When I mean estimating the threshold, I will not say it's an absolute threshold, to predict the threshold, and also to make a neurodiagnosis. Right. Now, this is a very important slide I want to highlight. See, ABR is not the test for nerve conduction. So most of the people think ABR is a test of nerve conduction. No, it is not a test of nerve conduction. ABR is a test of neural synchrony of the auditory nerve. That means the way the signal that travels in the auditory nerve is very important. There are some of the information travels synchronously, some information travels asynchronously. But when the signal travels synchronously, your brain can interpret it much better. When the signal travels asynchronously, your brain cannot interpret the signal, which means you will hear but you will not understand. Okay, and this is exactly what happens when there is a neuropathy. Now, when there is a neuropathy, the signal is traveling in the auditory nerve, but it is asynchronous. Because it is asynchronous, the patient will complain that I can hear sound, but I can't understand. Right. So, which means when you do an ABR in this particular case, you will not be able to measure ABR. The ABR will be flat. You will not be able to see these 5 peaks. You will have a flat response. Now, just because ABR gives a flat response, does it mean that the auditory nerve is not conducting information? No. The auditory nerve is not synchronously conducting information. Okay, so that's what it exactly means. So never ever diagnose just by looking at a flat ABR response as no nerve conduction. That's a very wrong statement to make. So this is something which is very important. I wanted you to understand. So as I told you, ABR will not give absolute thresholds. ABR but it's a very well proven and reliable test. ABR is a definite test to pick up any retrocochlear pathologies, which is for neurodiagnosis. Now, this is something which I want to highlight. So if you look at this particular audiogram, see, this is a high frequency and this is low frequency. At high frequencies, the hearing loss is significantly higher at low frequencies compared to the low frequencies. But when you do an ABR, and the stimuli that you give for ABR, you have to give an acoustic stimuli. If the stimuli is within this frequency, when you give a stimuli of a click stimuli with this frequency, within this frequency, the ABR will be poorer or ABR will be absent. But in the same patient, when you give a stimuli with this frequency, you will have a good ABR. ABR is near normal. So what is more important is when you look at a flat ABR, also look at what is the frequency that they have tested. They should have tested all the frequencies. Now, if they test only high frequency, which only means there is a problem in high frequency. If they've tested low frequency and high frequency, then you can say both low frequency and high frequency has a hearing problem. And you test a low frequency, you give a low frequency stimuli and you get a good ABR. You give a high frequency stimuli, you don't get an ABR, which means there is a significantly good hearing at low frequencies and poorer hearing at high frequencies. So whenever you look at an ABR, you also look for the stimuli what they've used to measure that ABR response. That's very important. Right. So I won't go much in depth of this. This is the cross section of the internal acoustic meatus, and this is the acoustic nerve, and these are the nerves, small nerve fibers that transmit signals. Now, for example, this is a high frequency, and this is a if there is a tumor which is compressing the high frequency, your ABR is poor. If there is a tumor, small tumor, which is also again compressing the high frequency, you have a poorer ABR. When you have a small tumor which is compressing the low frequency and then you're using the high frequency stimuli to test ABR, you will get a good ABR, but you will miss the tumor. Okay. So what is more important is you need to test the entire auditory nerve. The best way to test the entire auditory nerve is you need to give all the frequencies, stack it and give it so that you test the entire auditory nerve. So when you do it such way, even if there is a very small tumor, you can still pick it up. So that is the point. So the ABR is a very good tool, but there are a lot of parameters that you need to play with the ABR if you want to really make a differential diagnosis. Now, this is a very important thing. So there are, I mean, if you ask me, I can do at least 15 different types of tests using a simple ABR machine, and can assess different functions of the auditory system. That is quite possible. So the point is, it is not the equipment, it is the person behind the equipment which is very, very important for diagnosis. Now, the ABR is again a test which can test only up till the brainstem, not beyond the brainstem. So now what happens if there is a pathology beyond the brainstem? Of course, you can use middle latency responses and cortical responses to assess if there is a pathology beyond the brainstem and the auditory cortex. Now, one such clinical tool that we use in measuring the cortical response is called the cortical auditory evoked potentials. So this is the end of the roll at the end. So whatever is the signal you give, it has to reach the auditory cortex here to interpret the signal. So if I measure the signal in the auditory cortex, then I'll be able to understand whether the signal is reaching the auditory cortex or not, even if the patient is not cooperative. Now, what we do here is this is the auditory cortex, and this is the neurons. This is how the signal travels in the neurons. You can put two electrodes on the sides, and you can measure the informations. And when you measure the information, you'll be able to see a peak. Now, this is very important. What is the clinical significance of cortical evoked potentials? There are a couple of things that you can do. One is you can see whether the auditory cortex is maturing. So this is what I'm trying to show you now. Now, if you look at this graph, this is the age in this axis, and this is the latency, that is the time at which you can measure the this particular peak. Now, in a very young child, the latency of the cortical potential is longer. You see, it is 180 millisecond. As the age increases, okay, you see the latency is also decreasing. The latency is 100 milliseconds. Now, by by close to 400 months, you see, the latency comes close to 75, 50, 60 to 70 milliseconds. Now, what does it mean? It means when more number of neurons, when there is so much of auditory synapse, when there is so much of synapse in the auditory cortex, the time taken for the signal to reach and the time taken for the signal to be processed in the auditory cortex is much faster because of that. So now indirectly you are measuring the maturation of the auditory cortex by looking at the changes in the auditory cortical evoked potentials. So this is a very, very important tool, and the latency shift in the cortical potential is a biomarker for monitoring the maturation of the auditory cortex. This has been very useful in many situations where the patient has a hearing issue. We restored the hearing, but still the patient has not developed language and speech. The language and speech is completely dependent on hearing, but sometimes it is also dependent. It is not dependent. I wouldn't say it is not dependent on hearing. Hearing alone is not enough for good acquisition of language and speech. So in some patients where the language is not developed or acquired, if you really want to see whether the auditory cortex is maturing, you can use this particular tool to look at it. And this is very quite useful in my scenario. It's very useful when I do cochlear implants, and especially in the brainstem implant patients where the language and the speech development is very, very slow and poor. At least you will know by looking at the change in the auditory cortical evoked potentials that the auditory cortex is maturing. So this is a very important biomarker. And again, you can also use the cortical potentials for looking at many other cortical functions. There are hundreds of cortical functions you can use based on the event-related and non-event related potentials. That's a little advanced testing, but it is very much possible to look at the auditory functioning as well. Now, another test is to look at the automatic hearing test. For example, now the Puritan audiometry, as I told you earlier, it's a subjective test, which means each and every frequency you're stimulating and measuring the threshold. Now, for example, how do you estimate hearing threshold in very young baby? So one of the tests which has been recommended is auditory steady state responses. The auditory steady state response is an automatic test. So basically, it measures the responses of at the level of the midbrain or the brain stem. and then based on the level of responses, it will predict the hearing threshold. So ASSR is an auditory is an objective way of measuring the objective way of predicting the subjective thresholds. So that's another test that can be used. So this is a test which some audiologists prefer to use it, some audiologists don't prefer to use it. So depending on their skills, needs, and the clinical setup what they have. Now this I think I've already spoken to you earlier about it. Okay, the next important thing is the speech audiometry. Now, speech audiometry is very, very important because at the end of the day, if you look at the important components of hearing, as I told you, detection, discrimination, identification, and comprehension, the speech audiometry is the only test which assesses the comprehension aspect of it and the discrimination aspect of it. All the other tests which I've been talking about, right from pure tone audiometry to reflexometry to ABR, OAE, whatever I've been talking is only assessing the detection component of it. They are not even assessing the discrimination component of it. So only speech audiometry will assess the comprehension aspect of it. Okay, so this is a very, very important test which has to be done routinely in the clinic. And to perform this test, you need an audiometer. The audiometer should have a speech audiometry functions. So pretty much all the audiometer has got speech audiometry functions, right? And the speech audiometry gives a very good information about the level of comprehension of the stimuli, whatever you give, which is especially the speech, right? Now, there's another important set of tests that you can do called the central auditory processing disorders. Now, this is a very, very interesting thing because um, uh, there are a lot of disorders in the auditory system which is missed out, and there is a lot of disorders which we till now we were not able to even identify. Now, some of those disorders are the disorders which affects a child listening, which affects child's development of auditory skills. In fact, indirectly, it also affects the development of language and speech. Now, the central auditory processing disorder is a quite a common disorder in most of the children in India. Now, in MERV, we did a very, very informal study. We did a pilot project. So what we did, we screened hundreds of children in corporation schools, and we found almost 7 to 8% of the children in that school have auditory processing disorder. What happens because of auditory processing disorder? The children have difficulty in learning. Their scholastic performance goes down, and they become the school dropouts ultimately. So this is something very, very important test that to be done. And how do you do this test? Yes, this test also need to be performed using an audiometer, but the audiometer should have the facilities to do this test. So which means you need to use a true two-channel audiometer. So most of the audiometers available are single channel audiometer or pseudo two-channel audiometer. But only if you have true two-channel audiometer, which means there are two independent signal generators in the audiometer, you will be able to perform this test. So this is called the most advanced audiometers which is available. Of course, it is little pricey, but if you want to do this kind of testing, you really have to go for those kind of audiometers. Now, this is a very interesting thing that I will highlight. Now, if you want to assess the auditory nerve, for example, if you look at the here, this is a transduction process. This is the where the basal membrane and the tectoral membrane are moving up and down, and during this movement is where the sound is converted into electrical signal. Now, if the hair cell is not functioning, the sound is not converted into electrical signal. Now, in this particular case, how will you assess the auditory nerve? If the sound is transduced, and when the sound is transmitted in the auditory nerve, by measuring the auditory nerve function, you will know whether the auditory nerve is functioning or not functioning. When the transduction itself is not happening, how will you measure the sound conduction in the auditory nerve? That's a very important question. Now, it is possible. So what we do is we do a transtympanic EABR in our lab. What we do is instead of giving an acoustic stimuli, we put a needle in the inner ear and we give an electrical stimuli. When you give an electrical stimuli, definitely the auditory nerve will conduct the electrical stimuli. When the auditory nerve conducts the electrical stimuli that you stimulate, then using an ABR, that is called the electrical ABR, you can measure the information of the auditory function. So this I will not go much into detail. This is electrostapedial reflex. This is all when you put an electrode inside. That is for patients who's already been diagnosed. So when the electrode is inside the cochlea, or the electrode is in the or the device is in the middle ear, or when you put an device in the auditory cochlear nucleus. These are the tests. How do you assess the auditory function after implanting a device inside the ear? So I will not highlight much in detail, but just for information, even after you put an implant, whether it is in the brainstem or in the cochlea or in the middle ear, you can still assess the auditory function and see whether the device is functioning normal or whether the auditory system is integrating with the device perfectly. You can still be able to assess it. So the point is the auditory, the science of auditory diagnosis is advanced so much that you will be able to measure the auditory functioning at every level of the auditory pathway. Now, to conclude, if you ask me, is that any one single test which can be used for diagnosis? Yes, you can use it only to know the type and degree of hearing loss. But if you really want to do differential diagnosis to know whether the hearing loss is at the level of the outer hair cell or at the level of the inner hair cell or at the auditory nerve or the junction between the hair cell and the auditory nerve or in the auditory pathway beyond the superior auditory complex, or the problem is at the cochlear nucleus level or below the cochlear nucleus level or at the level of the cerebropontine angle. So if you really want to look at the differential diagnosis, you really have to use the complete test battery. That is very, very important. No single test can help you to do a differential diagnosis. That's very, very important. Now, this is something which is my own personal statement of so many years working in this particular field. I truly believe in this. I endorse it completely. The more and more I try to understand the auditory physiology, less and less I've understood about it. It is such a fascinating science where there is so much of work is to be done. But at the end of the day, all the hard works and the science that that you do to diagnose the patient, differentially diagnose the patient, when at the end of the day, it gives a very fruitful benefit because you can restore hearing in these cases. When you do all the diagnosis and you don't have a solution, then you really get frustrated. But none of us get frustrated because there is a solution. Even if there is no cochlea, even if there is no auditory nerve, we can still restore hearing using the implantable devices or whatever other solutions available. So the point here is the early identification. Now, this is a very important statement by Yoshinari Itano. She's a Japanese auditory electrophysiologist. Now, she published a paper in 1996 where she said, if deafness can be identified and treated as early as 6 months, at the age of 5 years, the speech and language development will be equal to the normal hearing period. This is a very, very powerful statement. But the point here is, will we be able to restore hearing by 6 months of age? If you ask me, yes, it is definitely possible. Now, okay, now how do you do it? So which means, will you be able to do differential diagnosis by 6 months of age? Yes, it is possible. Which means, will you be able to do all the tests that I've been talking about for the last 40 minutes in a child who is 4 months old, 5 months old, 6 months old? Yes, it is definitely possible. So it is possible to do differential diagnosis as early as 6 months. And it is very much possible to restore hearing as early as 6 months, which means even if the child is completely deaf, we can restore hearing to a normal level as young as 6 months old. That's definitely possible. But everything is possible unless we do a proper diagnosis on that. Now, what we have done is, this is the last thing which I wanted to tell, and we have several hurdles in this. One of the biggest hurdle is, being a very tertiary center for hearing restoration in this country, in this Asia, we still had a lot of challenges. One of the important challenge for us is to reaching out to the people. Now, so far for all these years, the people have reached. When we go, we do camps, we conduct camps, but at the end of the day, the people have to come to my place to do the differential diagnosis testing. Where in the camps you can only do screening, but with the new modality of teleaudiology, what we have, and we have ventured out with GenWorks now, and we are able to do the differential diagnosis even at their doorstep. It's definitely possible, and we've been doing it. So this is a very, very radical shift in the way the technology leads to gather patients for early identification and intervention, which is very, very important, especially in the state of Tamil Nadu, where the hearing restoration is completely funded by the state government. Because even if the child is born with a total hearing loss, Tamil Nadu government gives free cochlear implant, and the Madras Inter Research Foundation, the Murph Institute of Speech and Hearing, has been pioneering in cochlear implants for several years, which persuaded the government of Tamil Nadu to provide cochlear implants free of cost. So now we know that we have a cochlear implant, we have the solution for these children, and that's also affordable. Now the only problem is, how do we reach out to them to the differential diagnosis, to diagnose them as young as 6 months of age? Now this is something which is completely possible with the collaboration with the teleaudiology platform and provided by GenWorks and Murph. Together we have built a very strong platform now, and which we have been implementing it. So to conclude, today we are at a very fortunate situation. We are very fortunate for two important things. Number one, India has got the solution to restore hearing, and today we also have the solutions to pick up the hearing loss as young as 6 months of age. And now we have the facility even to reach out to any village or any nook and corner of this country, and we can still do the same level of differential diagnosis at their doorstep. It is definitely possible, and this is what we are venturing into now, and which we have been successful so far. And I would like to thank the GenWorks and NNF for the time and the opportunity. And if you have any questions, you may ask me either now or after the second presentation. Thank you very much.
Okay. Thank you, Mr. Ranjith, for your wonderful talk. And newborn screening is something which is very important, and this has become in most of the corporate hospitals. Newborn screening is a mandatory thing before they get discharged, and all the babies do get, and we follow what is called as 136 months policy.
Correct.
Within 1 month the OEE, 3 months BERA, and by 6 months, if baby needs any implants or hearing aid, we do provide that, and we do take help from institution and people like you. So yeah, we have touched the most important aspects, and most of the neonatologists and pediatricians who are working in government setup and even in private setup, they'll be very, very happy with your last slide, where you are trying to provide the hearing assessment at the doorsteps. So which is something which is very good, and which should it should start implementing all across the Karnataka. Thank you. So now, if you are okay till Vanam Naidu's talk, we'll have his talk first, and then we can take up the session if you have time, or else we can go for discussion for a few minutes and then start his talk. You're fine with waiting for his talk to get complete? No problem. Hello.
So I'm okay with anything. Yeah.
Okay. Yeah. Okay. So I request now Vanam Naidu Babu to start its session. After the end of this session, then we will go ahead with the panelists will express their views, and then we'll take up the questions from the audience. Over to you, Vanam Naidu.
Yeah. Good evening, sir. Yeah, you can hear me, sir.
Yes. Please
Yes,
make it slideshow, no?
Yes, sir. Yes, sir. Good evening. Good evening, everyone. Myself, Mr. Vanam Naidu Babu. I am CEO of Global Biomedical Services India, SN Medical System, and Indian Medical Mart. Our main branches are in Andhra Pradesh, Visakhapatnam, and Hyderabad. Branch offices are in Bangalore, Chennai, Mumbai, and
Vanam Naidu, just
yes,
1
sir.
second. You are speaking too close with the speaker. Can you just keep it little away, because it's disturbing? The voice is not that clear. Just keep it little away, your mic, and then you can speak. Yeah.
Yes.
Little closer. We can't hear.
Yeah, my educational background is
Good.
yeah, Bachelor of Technology, BTech Biomedical Engineering in Godavari Institute of Engineering Technology. It's in Rajamandri, and after that, I master completed in VLSI and embedded systems in GMR JINT Kakinada. It's in GMR. After that, we started a career as a employee. I started my working in Indus Hospital as a assistant biomedical engineer. I learned a lot of things in there as a maintenance of biomedical engineering, biomedical equipment, and all the documentation. After that, I joined directly in Muscat, Oman, Minister of Health. There is a opportunity like biomedical engineer. I worked for 2 years there as a contract. After that, we started as a SN Medical Systems. It's a startup company in the month of December 2015. Till date, we are running. I'm a CEO of SN Medical System. At the starting stage of investment is 60 lakhs. We started. After that, we believed in there. There is a lot of gap in between medical equipment suppliers and medical equipment calibration division. After that, we started. It's one of the medical equipment calibration division that's called Global Biomedical Services India. In that Global Biomedical Services India is there is a only we are doing in this firm. It's related to calibration. It's mandatory to every equipment we need to check in a 6 months or in a year. So for that one, we started in 2017 calibrations. It's all the test equipments we have for the medical equipment division. It's around 1.5 CR starting stage. Next, I can say my medical equipment. What are the ranges we are doing? I can say in Andhra and Telangana, and as well as now branches of office also it is there in Bangalore and Chennai and Bhubaneswar. There is all kind of services we are providing. Sales, we can say all kind of medical equipment we are selling, like OT and ICU equipments, as well as services. We can say all kind of medical equipment services we are doing. That we can say up to board level, power supply board and main board also we are repairing, as well as the rentals. I can say a lot of hospitals nowadays they are requiring rentals for the time being, means they cannot able to afford more price for as the equipment price, so that is what they are requiring rentals also. So that is what we started in 2018 rental also. After that, I told you previously 2017 we started calibration. Over a lot of difference gap is there for the medical equipment suppliers and calibration. Everybody is supplying medical equipment, but there is a lot of gap is there, a calibration services. So that 4 services we are doing, and as well as we are dealing with a range of SN medical. We are dealing different kind of different ranges of services. Calibration services, I already explained you. We are doing calibration services for all medical equipment services. We can say we are providing manpower services for hospital only, biomedical department, not other department. We are doing board level services also. Rentals, I already explained you. BiPAP, CPAP, ventilator, oxygen concentrator, monitor, and diathermy. As well as I told you, sales. Sales wise, I can say accessories. All equipments they are having, but some of the equipments are malfunctioning due to the cable weakness or cable some problem, faulty probe. So that's what we started accessories also. We are dealing all kind of medical equipment accessories like Philips, GE, Mindray, Spacelab, and L&T, as well as operation theater equipment. We are dealing in operation theater light and operation theater table, diathermy, vessel sealer, endoscopy, and surgical operating microscope, laparoscopy, and suction machine. Cardiology wise, cardiology, well, if I say ECG machine and TMT machine, and a new equipment what we are dealing with, neonatal division and baby warmer and double side phase phototherapy, blenders, bubble CPAP, and neonatal ventilators and syringe pumps, infusion pumps, and patient monitors and defibrillators. And baby warmers and phototherapy. Recently, we started manufacturing of this one phototherapy. We are trying to make warmers also. Our new introduction of phototherapy started soon. As soon as I will launch that brand name also. and syringe pumps and infusion pumps. Syringe pumps and infusion pumps are very important aspect or very important equipment. It is because rate also we have to check your rate, occlusion, everything we have to check it. Once we want to selling we want to take any equipment means it should be having calibrated equipment only. Why? Because if it is not calibrated, if a rate or volume it will be different, then it will be very uh, problematic to the patient. And defibrillator and monitor. Defibrillator new we are selling it Philips DFM 100, and the patient monitor we are selling in Contact CMS 8000. Accessories, as I explained in the previous, ECG cables, SpO2 cables, SpO2 cables, and NIBP cups, NIBP hose, IBP cables, and ETCO2 cable, and temperature temp cables, and all monitor modules for the modes and modules. Refurbished equipment. My topic is refurbished equipment. It is safe or safe and feasible. It means you're asking a question is refurbished equipment we can use it or not. I can say refurbished equipment is as my opinion. I'm saying refurbished equipment is feasible and safe to use. When it is feasible and safe to use, I can say every equipment is we are importing, like patient monitor, ventilator, defibrillator, BiPAP, CPAP, IABP, and heart lung machine, pulse oximeter are imported patient beds or CT scan, MRI. When we are importing, we have to have proper assurance like calibration and whatever it is there, consumables or accessories, like I can say CT scan if you take, there should be a tube should be changed and resetted. Must and should we have to see on our eye, then only we can confirm it is refurbished, its tube is changed. Unless until if we are taking with old tube, it will be maybe a very whenever they are going to change the equipment, like imported or somebody European countries or UK, US, wherever we are taking, they may be change only tube differentiation. When it is more years or more months or more hours it is used, then only they will change. So that is what we must and should need to confirm it is changed the tube, new tube only it is there in the CT scan. As well as patient monitor, if you take patient monitor, we have to check either its patient monitor is calibrated or not, then only we have to take. Otherwise it may be malfunction or it may be give wrong readings to the patient. Sometimes they may be think it is not functioning or it's giving inaccurate values, then only they will throw it out, means they will sell it out to the other customer. So that is what we have to confirm by each and every parameter, checking the accuracy of the equipment. And as I say, ventilators, what are the ventilators we are importing and we are selling in India? I can say mostly what are the changes we are doing in the ventilator, patient ventilator or monitor. If I say 110 110 volts, and it will be there 60 Hz, it is there in US and UK. Then here is 230 volts power supply will be there. We are changing the power supply from 110 volts to 230 volts. We are converting that power supply. After that, we are changing the filters also, as well as we are doing the calibration. Then only we are selling out the product in the Indian market. As well as following companies we are selling out in India. Macvet, Servo I and Servo S, Dragger. If I take Evita 4 and Evita XL, as well as HFO, high frequency ventilator SLE 2000. We don't have SLE 4000. Still we are selling out 2000 only. Newport ventilator, portable ventilator, Carefusion Nivea, all modes are there. As well as GA Angstrom, all modes are there. Nelcar Puritan Bennett 840 and Philips V100 and V200. As pictures we can see all the products what I explained in the previous. Dragger Evita XL and Macvet Servo I and PB840 and Macvet Servo S, and this Angstrom is a Dragger Evita XL and PB100 and PB200 and SLE 2000. Patient monitor. If I say patient monitor, what are the parameters we are changing in the patient monitor? As I said in the ventilator, as we are changing 110 power supply to 230 power supply. After that, filters we are changing and calibration we are doing. After that only we are selling in the Indian market. As well as what are the models we are having in the Philips monitors. MP20 also we are having, but we didn't mention it is not available in importing. So we are having now MP30, MP40, MP50, MP70, and MP90. I can say patient monitors. We can see all the models are there. MP, yeah, as I explained. This is also we can use as for the LAN cables, also LAN multi module connection, multi server also we can connect, and we can see it. All the parameters are accessible to that. All the refurbished, and it looks like new. It's not like old. Why we need to? I can say one thing. Why we need to use the old and imported products? Cost effective it is there. Most of them it is cost effective, as well as quality wise compared with Chinese products it is much accurate. So that is what we are buying these imported products. Defibrillator also, as I said, 110 power supply and 230 power supply we are changing. 110 they are using, now we are changing to 230, as well as filter changing and calibration and changing the cables. Following companies we are selling the defibrillators: Joel, Philips, Peugeot control. As you can see, Philips defibrillator and Joel defibrillator and Peugeot control, and BiPAP and CPAP. I can say BiPAP and CPAPs also it is there. We are selling large quantity of BiPAPs and CPAP nowadays. Those equipments are having a large demand. So those all equipments are same, like 110 power supply to 230, as well as filter cleaning and calibration. After that, following companies are available with us: Philips and Resmet. IABP, intra-aortic balloon pump. It's we use it for the cardiac patient monitor. This is also same like IABP. Also, we are changing 110 power supply conversion to the 230, as well as changing filters and calibration and cables changing. That's we are doing the balloon test as well as ECG simulation test. That's make we are having is MacWet. That MacWet we are having two models. We CS100 and CS300. The CS100 is a little older version. Now the CS300 is there. Heart lung machine. As like all the equipments, we are changing the power supply 110 to 230, as well as changing the filters and calibration we are doing, as well as we are doing occlusion test, filter cleaning, and pump checking. All pumps, 4 pumps we are checking, and after that only we are installing. Heart lung machines, now we are having SANS 8000 and SANS 9000, as well as a dragger also we are having. Pulse oximeters, patient monitor, as like I can say patient monitor, like we are changing 110 to 230. Availability companies are Nelcar and Massimo. These two companies are in Massimo and Nelcar. Portable also available with us. Radiology, CT scan. CT scan. Why CT scan we need to use as a refurbished? Why? Because their CT scan is having premium asset. This CT scan is a premium asset. Why I say premium asset? Lot of people they cannot able to access the CT scan nowadays. So that is what if the cost of the equipment is less, then they as per that hospitals or diagnostic center they will charge less. So that is what we are introducing refurbished CT scan. If you want to buy CT scan, we have to check as I previously said, tube machine should need to check. It should need to be new tube. Then only you can use up to 4 to 5 years. Other than this, it will be I cannot able to guarantee for 4 to 5 years. But if you are using less less quantity of CTs, then it will be 4 to 5 years. It will come. So that is what we have to check tube, and as well as we have to have, if you are buying CT scan, you have to know AERB and nuclear physician, and those should need to certify AERB certification. After that only you have to buy. As well as CT scan, if you want to use for ortho, urology, you can buy up to 16 slice. It is enough. As well as if you want to use for CT angio, cardio or peripheral, neurovascular, neuro intervention, cardio intervention, if you want to use, you have to buy for 32 slice. As well as MRI I cannot say more. It's also cost effective. It's if you are comparing with old one to new one. I'm comparing with some of the equipments, refurbished and new equipment. IABP, if you take new one, it's cost around 12 lakhs. Refurbished, it's cost around 6 lakhs. Heart lung machine, if you take refurbished, a new one, it is 60 lakhs. It is refurbished 30 lakhs only. defibrillator, if you take any DFM 100 or Heart XL, that DFM 100 is 2.5 lakhs plus GST, and this one is 1.2 lakhs. Pulse oximeter, if you take Nelcar, 35 lakhs, 35,000. This new refurbished, and a new one is 65k. CT also, it is like new CT, if you take 16 slice, 1.7 CR, it's a refurbished, it's cost around 80 lakhs. MRI scan 1.5 Tesla, if you take new one 4.5 CR, that is refurbished, it's cost around 2.5 CR. As I said previously, my task is pending. One is why you have to take refurbished or not. I have to finish first. Refurbished you can take, but you should not confirm. So you have to know authorized agencies and authorized persons, means like they have proper knowledge in the equipment. Then only you can buy the refurbished equipment. Mostly you cannot able to go with refurbished as a syringe pumps and all. Why? Because there is a lot of difference between new pumps and old pumps. There is accuracy of the pumps also. As my knowledge, a lot of old pumps they are not accurate as compared with new pumps. So better to avoid old syringe pumps using, means like imported syringe pumps and all. If you use, you will face a lot of problems. As I say, calibration services. We are doing all medical equipment calibration services, as well as QA for radiology, and as well as I said biomedical equipment consultant. Like when any hospital they required biomedical engineer, we are giving a manpower also. Medical equipment sales and service. And I can say now medical equipment market potential. Now the 135 crores population is there. More than 16,000 hospitals. Government and general district area hospitals are 2,000, and government and private teaching medical colleges are 412 plus. And medical device industry growth is more than 15 percentage per annum. And new government policies boosting medical device industry. As I can say now, AMTZ is there in Andhra Pradesh, as well as Telangana also. They are starting up some medical equipment manufacturing unit. And upcoming corporate hospitals are in the country. A lot of companies are there starting new corporate hospitals. As I can say, we should need to have one biomedical engineer for every hospital. Why? Because there is a mandatory for the every equipment. A small faulty we cannot able to identify. So that time we cannot able to call to the company person. They are available or not available. So that we must and should ensure that there should be one biomedical engineer for internal biomedical equipment maintenance. So for that one, you are having cost effective, as well as you are saving your time, as well as you can have plan for the next year what are the equipment and upgraded equipment you have to buy. Also you can come to know through biomedical engineer. What is biomedical engineering? I can say it's a challenging discipline. It's a combination of biological sciences and medical technologies. Both are included in this biomedical engineering. I hope every engineer having their knowledge, their own knowledge, and as well as medical equipment knowledge. What is calibration? What is the calibration and its importance? As I said, calibration is a correcting initial setting of measuring device by adjusting the device to match known and unknown measurements. This is like I can say, whatever old equipment are there, that equipment having corrupted or unusual reading. So that is what we have to ensure with master equipment and old equipment. We are checking master equipment is having calibrated. So with calibrated equipment, we will take multi-para monitor, and we will see that parameters it is proper working or not. That is like we can say calibration. Calibration ensure that reading offered by measured devices like scales, thermometers, and lab instruments are accurate and reliable. Manufacturers are measuring equipment often specify period of expected accuracy following the scale of an item. Often this period may be only a few months to a year regular use. At end of the period, the only way to return instrument to its original accuracy is via calibration. So we must and should need to do the calibration for every equipment every year. Why? Because there is a lot of differences are there. We are finding regular use equipment. I think it's less problem is there, but non-regular equipments there is a lot of difference are there. If we say more than 2 to 5% is accuracy, less than more than accuracy, less accuracy than that, we have to change, or we have to recalibrate, and we have to change the settings. Our range of calibration service: standard calibration services, including we are doing on-site calibration and pickup and delivery services, NABH and NABL traceable certificates of calibration, calibration label, calibration seals where applicable, recall notice when recalibration is due, general cleaning of the instrument, online download calibration certificate. This is our calibration services standards, including type of calibration service. I'm giving very few calibration services introduction. I can say electrotechnical calibration. We can say every equipment they're having electrical fluctuations and a lot of things are there. As I say, AC to DC voltage. We have to check AC to DC voltage must and should. If it is voltage is giving more difference, then monitor will be having some problem. So that is what we must and should need to assure that its equipment is functioning accurate and good functioning. So that is what every equipment we have to check: current, frequency, resistance, inductance, capacitance, high voltage up to 40 kV if it is taking the x-rays and all, high current up to 100 MA, AC/DC single phase at AC/DC power. Patient monitor calibration, it is there. This link I can say how we are doing calibration also, it is there in video. Now I cannot able to access. I can show you in the later session. Here how to do the calibration for the patient monitor, and I explained in this video. And the types of calibration service, as I said, mass, volume, and density calibration. Mass, volume, and density calibration, digital and analog weighing balances. All must and should we need to ensure that's correct reading and accurate readings are coming or not. Why? Because as an weight only we are giving the drug doses also. Full gauges and spring balances, load cell with indicators, and precision balance and physical balance. We have to must and should ensure this all the equipments are working properly. Then only we can any further diagnosis we can go. Types of calibration services, some of the calibrations I explaining. RPM calibration. If you take this centrifuge, RPM is very important to know that correct accurate RPM it is coming or not. If it is not coming accurate RPM, it may be diagnosis of that test, it may be differentiate. So that's what RPM should be. We need to confirm it is accurate RPM it is coming or not. We'll use as the tachometer, non-contact tachometer, as we show we have all the equipments. Types of calibration: pressure calibration. Pressure gauges are mandatory to check. We have to ensure that all we can say that oxygen flow and air flow and nitrous oxide flow, that is also mandatory to check. All pressures are coming accurate and perfect values. So that's what why should we need to know this accurate or not. If it is not accurate, if it is we are keeping 10 liters per minute to the patient, it will deliver 5 liters, then there is no cure to the patient. So we have to ensure that all flow meters and pressure gauges are working properly. If it is less or more, it is giving, it is effective to the patient directly or indirectly. So that's what we should need to ensure, must and should we need to ensure. Why? Because if it is giving any inaccurate unknown values, it will be dangerous to the patient. We are having ISO IEC certificate. Our calibration lab having this certificate 17025. It is valid to, we can do any medical equipment calibration. This certificate is saying it. Our calibration validity up to 31 October 2022. This ISO, we are also having ISO 901 and 2015, as well as we are in MSME also, small scale industries. Our calibration equipments, what are the companies we are having? I'm explaining you. Here we are having some of the equipment Fluke, some of the equipments are Regal, and some of them are Detran, and some other like ISO and ASI, some other calibration equipments are we are having. These all are we are having all kind of medical equipment calibration tools we are having with us. Our some of the corporate customers, I can say ONGC, Apollo, and Seven Hills, Medicover, Omni Hospitals, Yashoda Hospitals. I can say all top 10 hospitals. We are having five are our customers. So we are having throughout India customers. We have done a lot of hospitals up to still now 2017 to now 200 plus hospitals we done calibration. So we have use kind of experience. If anybody looking for the calibration, please contact us. And after that, we started a one online store. I said I am a CEO of Indian Medical Mart. We started a medical equipment online store. It's, we can say, a medical equipment sales and service and rental also we can book it, as well as you can find a best suitable price product in this Indian Medical Mart. It's a new introduction of new edition of 2020. Unfortunately, we could not find much market in this area because due to COVID, we cannot able to find much more margin. But we are future we are expecting good future for this Indian Medical Mart also. Thank you. Anyone having any doubts, sir?
Yeah, thank you, Vanam, for your wonderful session. And if you have a tight budget, or if you are having multiple branches and investment, if you're planning, um so it is very important that we handle our finance and accounts very well, and not to invest too much on things which we rarely use or which we commonly use, where hiring could benefit us more. So thank you for your insight, and I'm sure there are a lot of doctors would want to contact you, and you can post your contact number in the chat box, so that people who are interested in hiring equipments, they can utilize the thing. So now I request our panelist. I'll start with Dr. Ajit Kumar. He's my friend and he's an ENT surgeon, very famous ENT surgeon practicing in Dakshina Kannada. So I request him to share his views on hearing, newborn hearing screening, and about the 2 day session and his experience to all the neonatologists and pediatricians who have logged in. Over to Dr. Ajit. Ajit? Dr. Ajit? Kindly unmute yourself.
Yes.
Okay.
Am I?
Yeah. You're audible. I think the voice is breaking. You can switch off the video and then you can speak.
Right. It's good, right? Hello.
It's fine. Go ahead.
Yeah.
It's fine.
First of all, I would like to congratulate Dr. Ranjith. It's a very beautiful session. I think you have put up everything in a one beautiful session. Being worked in metros for around 4 to 5 years, now I have been shifted to periphery, and I worked in Chennai for 5 years. Now I am in the periphery of Karnataka. So there is a lot of problem when you work in. So whatever investigation or audiometry, BERA, OAE, everything. When you in a metros, it's like okay, you can do everything. When you come to the periphery, as you were told in the last few minutes or few slides, it is difficult to do or get a audiologist or equipments in periphery. So I think in the coming the era of digitalization or online era or something like that, we can have more of technology so that we can have more of I think even for it is the investigation will be available for the rural people also, or the patients who are settled in the faraway places. Second thing, that is, I think, one of the corner we have to look into. I think some app or something like that where you can getting more tests done for the periphery. So other thing, I think the setting of the pickup being early here, that is I think difficult part. So in periphery, I think we used to used to get a patients of 6 months, 1 year, or something like that. Okay, the doing for these people is very difficult. Okay, maybe after 4 years we can do with our own setup. Even we can do the audiometry, but like behavioral or play audiometry, all that things, it's very difficult to do by a ENT or something like that. You need a trained audiologist. At the same time, I think you need a setup also. So in our situation, like periphery, it is very difficult. So anything like maybe online things, I think will help more in this contest. Yeah, I think that's it. So we can go with that.
Thank you, Dr. Ranjith. Thank you. Now I request Dr. Meghna. Dr. Meghna, are you there?
Yes, sir. Yes, sir.
Yeah, kindly share your views, and you can even ask questions related. If you have doubts, queries, also you can ask our speakers.
Sure, sir. Sure. I think I am audible, right?
Yeah, we can hear you. Go ahead.
Yeah, first of all, I would like to congratulate Dr. Ranjith, sir. It was a very informative presentation. Really, you inspired us. It's been almost 7 years. I am in the field of child development. I do run a child development center, but mainly we do get a lot of concerns in learning disability. Because in case of learning disability, we have to go for hearing checkup. For that, till today, we don't have any idea which are the tests we have to take up, and especially for to rule out the auditory processing disorders. So could you please explain about that? It will be a good thing for us to more about that.
Dr. Ranjith, you can unmute and you can speak, Dr. Ranjith.
Yeah, am I audible now?
Yeah.
Yeah, thank you. Thank you for the nice question. It's a very valid question, and this is something which is very important because there is a very thin line between with the auditory processing disorder and learning disability. Now they go hand in glove together. But the test that I would recommend to rule out the auditory processing disorders, it's a combination of both the objective and the subjective test. First, we would like to, there are a lot of physiological procedures. I mean, there's a lot of physiology that we cannot assess with the existing audiological procedures what we have now objectively. So it's a very thin line. Now, the combination of the tests, that is, number one is starting from your screening checklist. It's called the APD, Auditory Processing Disorder Screening Checklist, which we need to take it up from the students or the parents who are working with the children very closely. Starting from that, adding up to the electrophysiological test of looking and measuring the functioning of the auditory system with respect to both the inner ear and the retrocochlear function. You can also do a lot of auditory processing disorder tests, like a simple test to the complex test, depending upon the age of the child. Now, you have a dichotic digit test, you have a figure ground test for a different function for memory recall, memory retrieval. You have a test for binaural integration, binaural fusion. There are multiple tests that can be done, but the point here is that each test is sensitive for certain group of for certain age group of children. So based on the age group, you can classify the test, and based on the specific type of processing disorder that is being suspected, or based on the specific type of complaint that comes from the parents and the teachers, we can also choose the test battery. So at the end of the day, if you ask me, is it possible to differentiate between learning disability with auditory processing disorder? Definitely it is possible, but there is a little bit of overlap between these two things with respect to certain age group of children. So that is where we really need to monitor them closely, where what we will do in that case is we will not be able to make a diagnosis at one shot, where we give them some intervention procedures, and then we monitor them over a period of time to see if there are any changes. So for example, if you could see some changes, then you can also, that will also help you to come to a specific diagnosis of what type of auditory processing disorder they have. So it is, to put it in a nutshell, that yes, it is possible, but there is some kind of what do you call it, as a fallacy in it, how we do it, that can be overcome by the type of test battery and the age, and based on the complaint of the child's skills. So we can definitely do that. That's no problem.
Thank you, sir. But to whom we had to refer? To ENT surgeon or speech pathologist, or to whom we had to rule out this condition?
Well, it's a very good question. So I think it's a team effort. So what we need to do is, now the processing disorder happens because of any change in the anatomy or any change in the function. Any change in the anatomy and the function can happen because of the pathology which is visible and the pathologies which is non-visible, non-invasives. So I think the best thing is to have a comprehensive workup by the ENT surgeon as well as the audiologist. Now they will be able to give a proper diagnosis, because the ENT surgeon will be doing his bit, looking at especially the wax. If you look at the Western countries, the wax management is done by the audiologist, but in India, the wax management is done by the ENT surgeon. So the otologist have to look at the wax management, and he'll also look at if there is any middle-ear pathologies available. Middle-ear pathology is existing in this case. And once he clears it, once he says yes, the child is okay to undergo audiological evaluation, then we take up and the audiologist will do the detailed audiological evaluation. So these are the two professionals who will be majorly involved in these cases. But and most of the investigations will be done by the audiologist.
Okay, thank you, sir. Thank you so much, sir.
Dr. Prashant? Dr. Prashant?
Dr. Ranjith?
Yes, sir.
Your voice is not audible. Yeah. We can't hear you. There's a lot of disturbance. Yes, Dr. Ranjith?
Sir, am I audible now?
Dinagar, sir, a lot of disturbance is there.
No, that's not from my side, sir.
I think Dr. Ajit has raised his hand. After Ajit, we'll go to Dr. Mridula, and then we'll take up the question. Yeah, you're audible now. Dr. Ajit? I think can you mute? There is a disturbance.
Hear me. Dr. Ranjith,
can you mute?
Your experience in doing online OAE or online BERA?
Sir, can you repeat the question, sir? If I'm not wrong, my experience on online ABR, right?
Yeah, ABR or OAE doing online.
Oh, yeah, my experience. Yes, we have done online ABR. Our first online ABR was done some 5 years ago. Hello. Yeah. So the first online ABR we tried out in the year 2004, somewhere in November or December 2004. That was our first experience on online ABR. So since then, we have been using online evaluations. Primarily, all my online evaluations for the last several years has been on intraoperative monitoring, where the surgeon is operating the OR in a different city.
Okay.
And we control and we take over the testing which is done from here. Now, if you and quite recently for last few months, we are also doing acoustic ABRs online. That's at the different cities and different places which we have installed, and this is something which we have been doing it for quite a number of times in the last 1 year. And if your question is very specific to it, and if you ask me what are the if it is useful, if it is very beneficial in the online ABRs, definitely it is beneficial. We can do online ABRs in two modalities. We can do an live online modality. We can also do an offline modality where you have the what we call it as a remote diagnosis. You can do online diagnosis and offline remote diagnosis, which we have been doing it quite often. So definitely possible. So it is not very difficult, but what is more important is you need to have a very strong teleaudiology tool to capture the online recording at the same pace of the time frame, because that is very, very important if you have to monitor. So you have a good internet connection to make sure that there is no lag between the recording and what you're seeing on the screen. And because it does not involve any patient's responses, you're only going to look at the wave morphologies in your screen. And even if there is a little bit of lag, yes, that is quite understandable, because you can still manage it. But the two important components that I would like to highlight in online ABR is two things. One, you need to have a professional sitting on the other side. Now, the professional needs to know how to fix electrodes. The professional needs to know how to primarily clean the scalp and fix the electrode. These are most important things. If a person with that particular skill is there on the other side, and if you have trained them, then rest of the things we can very well monitor online. From my clinic, I can monitor anywhere, because all the parameters can be manipulated using my computer from here with that particular equipment over there. So all that I need is a person who is very well trained to handle a baby or handle a patient in preparing the site of electrode positioning. That is very important. If that is done, then I think completely an audiologist on the other side can completely take over online. So you really don't need an audiologist sitting on site where you don't, I mean, what I mean is you don't need two audiologists, one audiologist sitting on site and one audiologist sitting in the control room. So you need an audiologist sitting on the control room. The person on site needs to have some basic knowledge about how to prep the skin and place the electrodes in the right positions. So if that can be done, and I think pretty much online ABR is very much feasible.
Yeah.
Thank you, Ranjith. Thank you.
Yeah. Now I request Dr. Mrudula. Dr. Mrudula.
Hello, good evening, everybody.
Good evening.
Good evening, sir.
Good evening.
So yeah, I'm very glad that I'm part of this webinar today, because Dr. Ranjith, I have been hearing about you all of my career in speech and hearing. So anytime anybody tells anything regarding cochlear implants or anything regarding brainstem implants, first thing that comes for us is Dr. Ranjith, because MERF is one of the best institutions where cochlear implant has been going on steadily since so many years. So as already you mentioned, sir, in the rural setup, what is happening? Because I was a part of district hospital Wenlock, and there what's happening, more of rural individuals come, and Karnataka government also has the scheme for free cochlear implants. So what is happening is in the rural setup, and still the awareness is poor. Even though we conduct a lot of camps and so many other things for the beneficiaries of the patients, still what is happening, they are thinking, no, my child will talk. They are unaware that their child is unable to hear. Correct. So when they come to us itself, they are around 3 years, they are 5 years. Correct. And by we identify and then give them, because the differential diagnosis can't happen in one day, so it will take some time. So when all that happens, and then by we go for the implantation or the hearing aid, it is again 7 years. We lost the critical period, and if the speech and here the speech therapy again to start that, and then the child acquiring the language is going to be difficult.
Right.
So this information what you gave regarding the doorstep online consultations or the doorstep consultations through the apps what has been designed now is going to be very helpful to the rural individuals now, sir. Thank you so much.
Very true, Mridula. That's very important, because even in our experience, which we have been performing cochlear implants under the state-funded scheme for almost 10 years now, little more than 10 years we've been doing now. And if you look at the first 3 years, the average age at implantation is almost 4.5 to 5. But if you look at with all the online the work what we do, the average age at which we do cochlear implant now is almost come close to 1.8 to 2 years. So this is a drastic shift, and I think it is a couple of things. Just not I wouldn't completely give the benefit to the technology alone. The awareness also goes keeps increasing as and when the patients keep seeing other implantees performing well. That is number one. And number two is the technology, like especially the teleaudiology what we have today, and the new methods of testing and the new methods of diagnosing them has really made the accessibility much more easier, because the affordability, accessibility, and sustainability are the three important things. Now, the first is, even if they can afford, they should be accessible to the clinic. Now, if they can access and get the treatment, they should be able to sustain the treatment for a long time. So what we are trying to do is, we are not just trying to do the diagnosis alone. So we are trying to bridge the gap of accessibility. Now, the accessibility also increases, the affordability also increases, because the amount of money that they're going to spend on traveling, the amount of money they're going to spend on staying in Chennai for 3 or 4 days for doing this diagnosis are all as a money save. So accessibility makes them little affordable also for the testing. Okay, and the sustainability is something which we are also working up, which is not very difficult with the kind of satellite centers what we have. So the technology really bridges the accessibility issue. It really helps the accessibility issue. When the accessibility increases, the affordability increases. This is something what we have seen in the last few years once we start working with this teleaudiology workup.
Yes, sir, very true. Because now, if I take Karnataka itself, there are very limited government hospitals which are recognized for cochlear implants. Private, of course, corporate hospitals, it is happening. But if you ask for the affordability or the accessibility, definitely, because when I was working in the district hospital there, it is one of the hospitals that was recognized for cochlear implants. But then the people who were coming to me were from different districts, and they had to travel nearly 2 to 3 hours. And for them to stay there and complete the procedures, entire thing. So it was difficult for them. They also had lot of difficulty in accepting that the child has an issue.
Yes, that is there everywhere, Mridula. They still have this difficulty in accepting the problem, because the good doctor and good audiologist is a person who speaks the same language as the patient. So if the audiologist, a good audiologist, a good doctor is decided by the patient based on what they're trying to say. If the audiologist says what the patient wants to listen to, they're called as good audiologist and the good doctor. It's always there. This is the cultural effect. But that will slowly go off. That's no doubt about it. But I think we need to keep penetrating. We need to use all the tools and all the modalities and all the resources we have to penetrate. Once we start penetrating, the penetration is going to be slow. It will have some resistance, but definitely we'll penetrate and we'll reach there. And beyond a point, you will see the penetration will be much more smoother, because you will have more people who have been benefited from the kind of work what we've been doing. So I think they will become the very positive ambassadors for this. So the point is, yes, one point I would like to highlight from what you've been asking. I think just by doing OAE screening and then ABR screening is not going to help. You need to take this complete diagnostic workup to the doorstep. unless we take the complete diagnostic workup to the doorstep, I don't think penetration is going to be a little easier. So, so that is why if you look at the comprehensive assessment, so we should not assess the patient based on the report. This is something which I always teach my students. Never make a diagnosis based on the report what you get. You make a diagnosis based on the patient. So you should diagnose the patient, not the report. So if you have to diagnose the patient, you need to have a comprehensive workup. The comprehensive workup includes complete audiological assessment, which includes both the external, middle ear, inner ear, both hearing, balance, everything has to be assessed. So the day we take up all the comprehensive tests to the doorstep, and that will definitely make the penetration much faster, smoother, and acceptance will also come much faster when we take it to the doorstep. I think everything matters, and I think we are in the right direction, and it's a matter of time. I think every will get these facilities, and we'll keep moving towards it. So we are. I mean, there are a lot of negatives about this COVID, but there is also some positive about this COVID. It has really put us into a corner where we really have to make use of this audiology telemedicine facility to penetrate as much as possible, which we've never taken into serious account so far. When I mean we, I don't mean we as medical professionals. Even the government is now really considering the approvals for telemedicines very seriously, which wouldn't have happened unless this situation has been thrusted upon us. So I think it's a kind of a blessing in disguise, and it's a matter of time. I think maybe after 5 years, when you have a very similar seminar, and when you're there on the other side, you will have a different opinion, and you will say, yes, a lot of people are now accepting, and then we will start discussing about other issues actually on it. So these things would have been sorted out.
Thank you so much, sir.
Thank you, Dr. Mridula. You can unmute and search.
Dr. Prashant?
Yes, sir. Yes, sir. We can hear you. Go ahead, sir.
It's a very nice topic, very nicely chosen speakers. And can I ask you one question, please?
Yes, sir.
Okay. See, now 17 key machine, what we are planning to buy. So that will be giving us even the sensorineural deafness, whether it is there or not, as well as whether it is something the problem is there in the even hearing. Both it will give. Suppose if I'll buy the 5 keys, it can give only one. So which one you people suggest for everybody to buy?
Well, if you ask me, I will ask you to buy the 17 key machine, because
please.
Sir?
Yes, sir.
The 17 key machine, I'll tell you why. Number one, if you take the 5 key machine, okay, let me explain what he means as 17 key and 5 key. I think he's talking about the Natus equipment. The Natus equipment, the OAE plus automated ABR. It's an inbuilt
yes
tool. The 5 key, what you're talking is only the OAE screener. So the OAE screener is nothing but it is only evaluating the outer hair cell function. As I clearly mentioned, just because the outer hair cell function is normal does not mean the entire auditory system is absolutely normal. Now, for normal language and speech development, you need to have a normal, the entire auditory system has to function normal. And quite often we pick up a lot of children with neuropathies or maturational delays where the ABRs are absent. So which means the outer hair cell is functioning normal, but the child will still not be able to develop normal language and speech. So the question here is, are we screening the child for outer hair cell function, or are we screening the child for hearing? If you want to screen the child for hearing, I think you need to use both the tests, because both the tests has its own positives and both the tests has its own negatives. One of the biggest negative of OAE, which is a 5 key machine, is OAE machine. For example, if you cannot measure an OAE, it does not mean the outer hair cell is not functioning. You have to keep that in mind, because if the child has got any middle ear pathology, if there is a negative pressure in the middle ear, if there is a fluid in the middle ear, which is quite often present in infants because of the straight eustachian tube, the milk and all those things can go and settle down in the middle ear. The OAE cannot be measured because the emission has to be measured in the ear canal, and the emissions has to pass through the middle ear for the microphone to pick up in the external ear canal. That is the most important thing. If there is a middle ear problem, the emissions will be very low and the microphone in the external ear canal cannot pick up the information. So if the OAE is absent, it does not mean that the outer hair cell is not functioning. But if the OAE is present, it means the outer hair cell is functioning. Okay. Now, in a case where OAE is absent, you do an ABR, and if the ABR is present, okay, which means hearing is there. Okay, and also it means that the auditory nerve is conducting the information synchronously. Right. So when you use both the tools, when you use combination of both the tools, I think that's better. Or you use, in case if you can't afford a 17 key machine where you cannot buy a combined OAE and ABR tool together, and you can only afford to go for an OAE machine, yes, you get an OAE machine, but follow the principles. The principle rule: if the first testing with the child fails, we will not call it as a fail, we'll call it as a refer. So when you refer, you again do an OAE after a gap of 1 month so that the middle ear fluids are settled down. And before you do the second OAE, do an emittance audiometer. When you do an emittance audiometer, you see a normal tympanogram, and then you do an OAE. And then if you get a absent OAE, it means outer hair cell is not functioning. Right. Now, if you want to skip this and you want to really quickly make a screening and an inference out of the screening, you can do both the tests at the same time, one after another, so which will give you a quick report, and it will also give you much more information. So that's the advantage of using OAE and ABR together. So if you can afford both the machines, I would recommend you to buy both 17 key machine, which is a combined unit of OAE and ABR.
I have one more question. It's
Yes.
a very nice explanation, beautifully explained about 5 keys and 17 keys. So suppose if anybody buys the 5 keys and if it is present, it's very good. But there is some problem in the nerve or supraalveolar, wherever the problem. I don't want to tell only nerve or wherever the area. Suppose now it is OAE is present, we are sending them. Future, they are observed, child is not able to talk or listen, then they got the report. Do you think they can sue us? We have got it, they told it is, means it's a present, it's not a referral that time, because the outer cell is functioning.
Got the point, got the point. So it's a very valid question. See, a couple of things. See, if you look at, there are 2 types of babies we classify. One is well babies, another one is a high risk babies. Now, in high risk babies, okay, what we recommend is, even if the child passes all the screening tests, the child has to be followed up for next 5 years, because in patients with, in high-risk babies, there can be a late onset of hearing loss, which is quite possible. So this information has to be clarified to the patient very clearly. Okay, and if you want to make a note it down and make a consent, you can get it done. And the second important thing is your first question: if the later, if they find that the child has got a problem, now the question is, there is a possibility that the child can lose hearing at any point of time, but there is no way that they can say the child had a normal hearing at birth and lost hearing later, or the child was deaf from birth. So unless otherwise you document it periodically, it is very difficult for you to pinpoint at what point of time the child lost hearing. Because there are 100 reasons, as a doctor, there are 100 reasons why a child can lose hearing. Right. Now, it's very difficult to tell. But the most important point I would like to highlight here is, this is very important that we need to educate the parent. We need to tell them, yes, this is a screening test. This screening test is done just to check the outer hair cell function. The outer hair cells are perfectly fine. However, the child, in case if the child develops, if there is a delay in the language, if the delay in the speech, they'll have to meet the respective consultant, the pediatrician or a pediatric otologist or an audiologist, to take an opinion from them. So they cannot sue you. So the screening itself means the child outer hair cell function is perfectly fine. But still, the child has to be monitored. Everybody has to monitor the child because onset of hearing loss can happen at any point of time. So as of now, the rule is if there is a high-risk baby, the late onset of hearing loss is quite possible. So they'll have to follow for 5 years. If it is a well baby, very unlikely.
So Dr. Ranjith,
yes, sir.
Number one, with this this thing, because we pediatricians are neonatologists, we do one screening. We know that we are doing either OAE, because if we are starting in the periphery, either 17 key or 5 key. Suppose if they are not affordable, so they will buy the 5 keys. So what you mean, what you are telling is, once if you buy the 5 keys, try to request them or write it, periodical hearing test is recommended.
Yes, if it is
because we know that we have to diagnose the hearing loss in 3 months.
Yeah.
So better to write it medico-legally, or because they have gone, because in this scenario, we are very busy. We are seeing 120 cases, and with that we are taking care of neonatology. So in that context, so we do miss, our sister do miss.
Correct,
if we are buying keys. So 17 keys anytime better. In that regard, what is your take-home things?
No. See, it is two things. One is you buy a 5 key, and even if the child has got a normal hearing, because of procedural error, you can make say it is a refer, right? So we only talk about considering all those factors are controlled, and if really the patient has got a problem, you're going to report the patient has got a problem, refer. If the patient has got normal hearing, you're going to say at that point of time the hearing was normal. The outer hair cell function is normal. That's all. So that's what we can report. Now, the duty of the parent is, we cannot guarantee, we can only do the hearing screening. So hearing screening does not mean we are projecting a auditory horoscope for the next 20 years or 50 years of the child's life. At that point of time, the hearing is fine. Whatever happens later is absolutely not at the purview of the physician or the clinician or the audiologist who's doing it. So my worry would be, or my concern would be, whether the procedure what is being done at that point of time is done properly. Considering all the factors, if it is done properly, what we report is, yes, the autoacoustic emissions are present. So the child's hearing is fine, but the quality of the hearing cannot be assessed using screening. The screening will only tell whether the hearing is present or abnormal. But how much of abnormality, what is the quality of the normal hearing, it is not under the purview of hearing. If the parents are concerned, yes, they can go and get it done later if they see any symptoms in the auditory skill development of the child.
Yes, sir. And one more small thing. Suppose we are doing the ABR, so the test is, we see the okay, the test is negative, the baby is not able to hear. And when we do the diagnostic ABR, so I heard that there are 7 waves are there, or I don't know, 8 waves are there. In that, each wave will tell where is the lesion. Can we diagnose? So I am the neonatal. Can you diagnose? Parents sue against neonatologist. This hearing loss is occurred because of the drug, or like any ototoxic drug. Can you diagnose in the diagnostic ABR?
Sir, using an ABR, we cannot look at the effect of the drugs on the hearing. It is difficult. But using an OAE, we can do it. If you use a diagnostic OAE, we can do it. But nobody suspects, but for that, you need to do a serial OAE. For example, you give an OAE before the drug. You do an OAE before giving the drug. After administering the drug, you do an OAE. Follow it up every 15 days or 30 days. And if you see a change, then you can say it's because of the drug. Now, and you're going to do one OAE as a cross-sectional, and then with that OAE alone, you will not be able to say it is because of the drug. Maybe looking at the history, you can predict it could be because of ototoxicity, but you cannot prove it. It's only because.
No. Why? Just it is only thing because only it is because of the drug. Like that, parents cannot sue us in the any test.
Sir, you cannot see. It is not possible because where is the evidence for that? See, if somebody is suing you, they need to provide an evidence. So they can't sue based on their own imagination, whims and fancies, or somebody is asking them to do it. Everything needs evidence in the court of law. But the court of law evidence is you need to have a CLOEs to prove that yes, gradually the hearing has gone down and because of ototoxicity and pre-drug exposure. So if they can prove it, then fine. That's a different story. If they can't prove it, then how can they can only claim or proclaim, but they can't. Yes. There is no evidence to do it.
Okay, so just one small thing, Ranjith. Sensorineural hearing loss. That means, is it a cochlear problem or is it a nerve or anywhere in the lesion of the nerve or?
Very interesting question, sir. Very interesting question. I'll tell you
why I am asking, Ranjith. There is a medico-legal case is going on one neonatologist. There is drugs causing sensorineural hearing loss. So OA is passed. Later, child is treated because of something in some medicines. So sensorineural hearing loss has come. There is a waves, and it is still case is going on. That is the regard I asked you. You are the master in that waves and.
I understood, sir. It's a very good question because there is nothing called the sense. See, I would put it this way. Earlier, we termed it as sensorineural hearing loss because we did not have the tool to differentially diagnose between the sensory hearing loss and the neural hearing loss. Okay. But today, we have the tool to differentially diagnose between the sensory hearing loss and the neural hearing loss. Okay. So today, there is no need for us to write it as a sensory neural hearing loss. Right. So if you can evaluate a sensory component and if you can evaluate a neural component, you can very well write moderate sensory hearing loss or moderately severe sensory neural hearing loss. Or you can also write as moderate neural hearing loss. It is possible to write. So this is why you need to do the differential diagnosis in this case. Now, coming back to your question that somebody has been sued because of sensorineural hearing loss and ototoxicity, I'll quote the previous answer. See, unless they prove it is because of ototoxicity, this is not going to be valid. And proof of ototoxicity is not just by looking at what drugs he has taken. Right, it could be because you need to prove it with a serial measurement of the effect of the drug on the particular system which has been affected.
Yes.
Dinakar sir, do you have any other questions, sir?
Prashant?
Yes, sir.
Yeah.
Yes, sir.
Can I ask for our Naidu, Mr. Naidu?
Yeah,
can you
go
answer?
ahead, sir.
And Ranjith,
Go
thank
ahead,
you
sir.
very much. Sorry.
Thank you.
Because
Thank you.
It was a very nice session. I learned from you many things. Thank you. Thank you. Naidu? Mr.
Yes,
Naidu?
sir. Yes, sir. I'm here.
Your talk was very nice. So is there calibration? Suppose after buying the calibration, do you think, because it is in the warranty for 1 year, so we bought the highest, best syringe pump or infusion pump. It's in the warranty. Now it is 1 year is over. So how often we should do the calibration? Not for the NABH purpose, for our own safety purpose. Time limit.
Yes, sir. Yes, your question is very nice, sir. I can say every 6 months we have to do because as per usage or as per our technical things, I can say every 6 months should need to do the calibration for syringe pumps and infusion pumps.
Every 6 months. About the monitor, SpO2 monitor.
As like we can say that is AMC and CMC. Every company they are keeping AMC and CMC. That is called AMC means annual maintenance contracts. That is called calibration also included in that. So we must and should need to ensure all the equipment functioning properly with calibration every 6 months.
So syringe pump, infusion pump is the main. And regarding the ventilator, just I thought I'll ask you. Now the ventilator in a neonate, everything is, what is it, that sensor will come with a platinum filament, or I don't know whether it is a gold, or I don't know what type of filament the people are using. Okay, so if that filament if that filament is there, and some ventilators will have a air sensor, you know that. So
Yes,
which
sir.
one is far better? Because they claim both are having the volume guarantee or volume assured. So which one is more better?
Filament, I can say ventilator is measured lot of things. We can ensure that filament is there, that is much better than compare with sensor.
Okay, so instead of air sensor, filament sensor is far better.
Yes.
Because yes, air sensor never goes wrong. Wrong means it never, because if the filament is there, some secretions will come and blocks. And always we have to change every 24,000 rupees give, or
Yes,
12,000 rupees to give.
yes,
We have to change, because some people. So how much difference it will come, because you are doing the calibration.
yes,
How
sir.
much both the sensors will have a differentiation. Suppose 1 kilo baby I am using, 1 kilo baby. So I am using the filament one, or I am using the air sensor, something like Bella Vista something. So what is your experience in that?
Can you repeat please once again that question? I cannot able to understand.
So suppose if you are using the filament sensor or the air flow sensor, flow sensor, another one is filament sensor. I am using 1 kilo baby volume guarantee. How much difference in the calibration you will get when you are using the both sensor?
Yes, sir. This is a very good question. I can say mostly in airflow sensor it will come around 5%. In this tungsten filament, if you use as a flow sensor, it will be around 2% only. It will come.
So 2 to 5% it will come.
Yes,
Okay.
yes.
Yeah. You are the one more topic you covered about the minimal things about the Do you think is it safe for us in the periphery to use? Because it will work out for us, because in Bangalore the people do pay, in metropolitan the people do pay, but in periphery their payment is very less. So do you think refurbished will really work out, or it is always not good to use? What is your impression, sir?
As I can say, some of the equipment we cannot able to use refurbished. As I previously said in my presentation, syringe pumps we cannot able to use as a refurbished equipment, but most of other equipments we can use. We should need to ensure that all the equipments is done proper calibration, proper checking, and each and every component checking, and each and every parameter is checked. Then only we can use that refurbished equipment. That is safe. Ensure we can use the refurbished equipment. Must and should we need to know that all equipments are calibrated, and all equipment testing and calibration done, as well as safety also done. All parameter ensure, then only we can take the refurbished products.
Hello.
Yes, Dinakar sir, do you have any other questions, sir?
Yeah, Prashant.
Yes, sir. Yes, sir.
One small thing regarding the ventilator. Mr. Naidu, what is your take-home message regarding the ventilator? Refurbished.
Once again, sir, can you repeat, please?
Ventilator refurbished.
Okay.
How to choose the refurbished ventilator for neonates, pediatric adult? How to choose?
Better way to go with a new one only, sir, because ventilator is very for the neonatal, I say refurbished is not suitable. Why? Because there is a lot of parameters are there. If you go with the neonatal refurbished, if you go with high frequency any ventilator, it is not suitable to go with refurbished. Most of the equipment you go with means ventilator wise, if you take any ventilator, very few kind of a ventilator like MacVet, if you take, it will be reliable. and cost effective and good equipment. If any other equipment, if you are going, you go with new one only. You don't go with other equipment for the neonatal, because MACVET only suitable for with means every equipment is suitable, but compare with the new one, accuracy is little far. Means new one, if you take accuracy wise, 2 to 3% only accuracy less compare with 100% if you calculate. If you take refurbished, it will be around 8 to 10% it is there. So better way to choose new one. If it is possible, you can go with if you have available with MACVET Servo I or Servo S as a neonatal mode, you can go with that.
Okay. So thank you, Prashant. Thank you, Naidu. Please. Thank you, Dr. Ranjith. Please.
Thank you, sir. Thank you, sir. Now, I request our delegates, if they have any questions, they can unmute and they can ask directly. I think most, I can see somebody who has raised the hands.
Hello, sir.
Kindly
Am I audible, sir?
Yeah, please. Yeah, go ahead.
Sir.
Yes. Is it
So
logical
what's the life
to
of filament sensor,
do the...
sir?
One by one, you can ask the question. Naresh, sir, go ahead, sir.
Is it logical to do audiometry in every case of child with speech disorders?
Sir, can you repeat the question? Is it logical to do audiometry in every case of?
In every child with speech disorder.
Has to be done, sir. It is mandatory. The moment the child walks in with a speech disorder, we have to do a complete audiological evaluation. It's just not audiometry. You have to do a detailed audiological evaluation, because speech delay could not because of hearing loss. The speech delay could also be because of auditory processing disorder. So it is mandatory that the child has to undergo a detailed hearing evaluation. And if you look at our protocol in MERV, we have a little elaborate protocol. We don't do just audiometry alone. We'll also recommend for psychological evaluations and developmental assessments, speech language evaluations as well. So unless we do all these investigations, we will not be able to come up with a comprehensive diagnosis of the disorder.
Sir, what is the cost of the cochlear implant, and which center is the best in India? I am from Jharkhand. Where to refer these children to the appropriate center?
Sir, there are a lot of good centers in India. I think if you are from Jharkhand, you have to look for centers somewhere close to UP or I personally don't know any center in Jharkhand, but I can find out for you. That's not difficult for me. Maybe you can take my number from your I think Dr. Prashant might be having my number, or Genworks may be having my number. So we will try and find a center which is closer to you, because most important is you need to find a good center closer to you. There may be centers. Choose a good center closer to you. There are quite a lot of good centers in India. There's no doubt about it. And the cost of the cochlear implant is the minimum cost of the implant would be around 5 lakhs, 5 to 5.5 lakhs.
Sir, there are many types of alarms and the various instruments producing sounds in the BG NICU. Does it cause hearing impairment in the newborn?
Very good question, sir. Sir, I think if the noise is, if you look at the occupational health and safety for the acoustic damage of the hearing, is if the exposure to sound is more than 85 decibels for a period of 10 hours over a period of few months, then they may have a permanent hearing loss. Otherwise, they will have a temporary threshold shift where the hearing thresholds may shift a bit, but it can recover back. So I don't think the noise level in the NICU can cause a noise-induced hearing loss to patients if the noise level is not more than 85 to 90 dB, and it is over a period of 10 hours a day for a period of few weeks. So I don't think it will happen. Unless otherwise there is a very acoustic trauma. Acoustic trauma is a noise blast. If there is a very abrupt blast, very loud blast of more than 150 dB, then it can damage the hearing. And if it damages, it doesn't damage for the children alone, even damages the neonatologist standing next to the child. So that's the level of noise the child need to expose in case to cause a permanent damage.
Is it a ethical practice to put cotton ball in every newborn having exposure to these sounds for prevention of the hearing impairment?
So cotton balls, I don't know how much the cotton ball will attenuate. At the end of the day, how much the thing attenuates is more important. Now my question to you, sir, is it so noisy in the neonatal ward that the noise level is more than 90 dB and the exposure is continuously for more than 10 hours for a few weeks? Does it happen? I think the children are discharged within 72 hours or so. They're not going to be in NICU unless otherwise they are high risk babies.
Many newborns stay for a pretty long time, and where very many NICUs are very busy with these sounds, of producing a lot of sounds, and how much how they are giving control over it. I don't know.
So this is a very good study which can be done actually, but I don't have any official documentary evidences to say that yes, this NICU can have can affect hearing in children. But my way of understanding is this. See, the hair cells are much more stronger in children compared to adults. The hair cells are weaker as the age increases. That's why the OAs are becoming very weak as the age increases. Now, if the NICU noise can cause hearing loss to adults working in NICU, then it can cause a hearing loss to children, young babies in NICU. So I think it's much more easier to evaluate the adults working in NICU for a longer duration to see if there is a threshold shift. So based on that, we may be able to predict it, or we may have to constantly monitor the OAE. We can do the OAEs periodically to see if there is a change. But I don't think if we have, as of now, I have any documentary evidences to say whether it will cause a damage or not.
Thank you, sir.
So regarding the flow sensor, sir, filament sensor, sir. Hello.
Please go ahead. Please go ahead. You can ask the question.
So,
We can hear you.
regarding the filament sensor, can you give some practical tips to increase the longevity of the sensor, sir?
Hello.
Sir,
Can you repeat the question?
Can you give some practical tips to increase the longevity of filament sensor, sir, so that it is not needed to change it frequently?
Yeah, Naidu.
Yeah, ma'am.
Yeah, Mr. Naidu, question is for you.
Yes, ma'am.
Naidu, she's asking what are the steps to be taken in order to increase the life of sensor. What they need to do while handling the ventilator, how to handle well in order to prolong the life of sensor so that it doesn't get spoiled quickly.
Okay, thank you for valuable question. See, mostly sensors are frequently it will go off. Mostly that filament will not go off normally. When it will fall down or when it is somebody unprocedure taking out, when we are taking we should need to ensure that equipment is shut down and then only we need to take it out for cleaning or anything for maintenance, as well as if it is fall down immediately it will disappear, means that filament will go off. So machine should ensure, machine should need to switch off and take it out, then clean and proper insertion also very important. Pins are connecting properly or not. After reinstall properly, then only we have to switch on the machine. Only there is no means secret in that flow sensor maintenance. Only we have to ensure machine is switch off. After that, we need to take it out and insert. Then only it will. Then only it will increase the life of the flow sensors.
Yeah, I hope. Hello. I hope he has answered your question. Any
Yes,
other
sir.
delegates have any other questions? They can unmute and they can ask. Yeah, I can see somebody who has raised the hands. Please unmute yourself and ask the question. Delegates, if you have any questions, you can ask. All right. I think looks like most of the doubts are cleared. On behalf of NNF Karnataka, we would like to thank our speakers Ranjith and Naidu for their wonderful presentation and their time, and our panelists Dr. Ajit Kumar, Dr. Meghna, and Dr. Mrudula for the participation and giving valuable inputs and insights into today's topic. So we have our President NNF Karnataka chapter, Kotreshi sir. Kotreshi sir, are you there? Kotreshi sir, are you there? Yeah, I think some technical issues. Kotreshi sir, are you there? All right. So it was a wonderful sessions and discussions what we had in detail. So I would like to thank our speakers